Good afternoon. My name is Dr. Marcus Noel, and I'm a GI medical oncologist, associate professor of medicine here at the Lombardi Comprehensive Cancer Center.
And I'm Ben Weinberg. I'm also an associate professor of medicine and GI medical oncologist at the Lombardi Comprehensive Cancer Center.
So we're excited to discuss some updates in GI cancer, focusing on novel therapies, targeted therapies, just discussing what's going on in the field of GI cancer. So let's start with pancreatic cancer. Dr. Weinberg, you did a recent nice review for the ASCO session. So let's start with targeted therapy in pancreatic cancer and discuss what's going on there. I'll throw the floor to you for initial comments there.
Yeah, so pancreatic cancer, as you well know, has been a really difficult cancer to target in a variety of ways. The vast majority of the cancers are driven by a mutation in KRAS, which has been historically very difficult to target. There is some light on the horizon targeting KRAS G12C, which is a rarer variant of the KRAS mutation, but is seen not uncommonly in lung cancer, colorectal cancer, and in pancreatic cancer. And there is some early sign that these novel targeted pills may play a role in the management of patients with these less common KRAS mutations. The issue seems to be, at least in the lung, colon, and to a lesser degree pancreas world, that these very targeted drugs breed resistant mutations, and patients are able to derive benefit from these pills, but it's relatively short-lived, and then some other resistance mutation pops up, and then we need other drugs to sort of target the resistance mutations, and we're learning a lot about what these mutations are, and conceivably other drugs that might be able to target them. The other thing I know that's been exciting in pancreatic cancer has been drugs that target, the BRCA, the homologous recombination repair pathway. What sort of is exciting to you in that realm?
Yeah, so we know that the recent FDA approval, or over the last few years, relatively recent, olaparib has been exciting in pancreatic cancer. So BRCA1 and BRCA2 mutations are the most common hereditary mutation in pancreatic cancer. And so we finally have positive data from the POLO study, which was really exciting at ASCO a few years ago, leading to the approval of olaparib for maintenance therapy in BRCA-mutated pancreatic cancer. And so that was a huge breakthrough, the first targeted therapy that we have approved in pancreatic cancer. And so really the question is, how can we build upon that? There's some controversy on that study in terms of are we going to see a true improvement in overall survival as the data matures, and really building on, can we look at more mutations in that space, whether it's ATM or other HRD mutations to further target use PARP inhibitors in that space. So I think there's a solid foundation to build upon there, and it'll be exciting to see what comes about as we continue to study drugs in that space.
Yeah, the other thing we've seen, and this was just presented a little bit at this year's ASCO, this group that is the 8 to 10% that does not have a KRAS mutation, for example. We think that group is heavily enriched for the potential benefit from other targeted therapies, because if it's not KRAS, there must be some other driver event. And we do see rarely these patients with BRAF, HER2, other potentially druggable, targetable alterations. And I guess the newest kid on the block is an area of interest here, which is the NRG1 fusions, which are very rare genetic events where NRG1, which is this gene that regulates this nerve receptor in the brain, somehow gets tagged or glommed onto some other completely unrelated receptor, and this activates the HER signaling pathway. And we now have a family of drugs that might be able to work and target that. And one of the ones that was presented at this year's ASCO specifically focused on this group of KRAS wild-type pancreatic cancers that has NRG1 fusions is this drug zenocutuzumab. And they showed that, again, in a few patients, there seems to be a good tumor shrinkage or response rate to this drug. And again, it sort of behooves all of us to do very broad genomic sequencing of these patients and things that might be missed in things like liquid biopsies in order to find these rare genetic fusions. On top of what we should be doing in all these patients, which is good germline genetic testing, because we know we can find those BRCAs, those PALB2s, ATMs that are inherited, even in patients with really no family history. We know that they're out there, and that anybody with a diagnosis of pancreatic cancer should have that.
Right.
What about immune therapy? Where does that stand in terms of pancreatic cancer?
Yeah, so it's a very common question for our patients. I think patients come in and always want to know about immune therapy, and really we've seen the most success in MSI high tumors, these tumors that are microsatellite unstable, and really confer the most benefit to immune therapy. Unfortunately, in pancreatic cancer, as you well know, these mutations are quite rare. Less than 2%, 1 to 2%. And so for a very small set of patients, immune therapy is a great option, but in the majority of patients, we cannot utilize immune therapy. So the question is really how can we turn these cold pancreatic tumors into hot tumors? And at ASCO this year, there was data looking at the CD40 immune therapy combination. The phase 1 looked really promising, phase 2 not quite as much so. But I think it's important to continue to build in that space to find a better partner for PD-1 in pancreatic cancer.
Yeah, I mean, that whole area of study has been very disappointing to date. And while immunotherapy has been this sort of blockbuster revolution across lots of different tumor types, those seem to be the ones that are more, smoking related, UV radiation related. So we're talking like lung cancer, melanoma skin cancer, bladder cancer, kidney cancer. For whatever reason, most of the GI cancers we treat don't have that, what we call sort of high tumor mutational burden. We think the more mutations the tumor has, the more abnormal it looks to our immune system, the better able our immune system is to recognize and kill it. Pancreatic cancer is sort of the poster child for a very immune-resistant, immune-refractory tumor, both because it may only need one driver mutation like KRAS to form, doesn't need hundreds, thousands of mutations, but also, there's this dense, like, desmoplastic stroma that, like, microscopically seems to wall off the tumor from blood vessels, from immune cells, from chemotherapy, targeted therapy. So I agree. I think, we're looking for that magical combination to sort of crack open this kind of steel cage. And so far, it really hasn't seemed to work. And on top of it, these folks, with advanced pancreatic cancer, really have to remain on some form of chemotherapy, or the tumor grows so quickly that we can't even give the immunotherapy a chance to work because it doesn't work overnight. So I agree that some of these combinatorial approaches, a different checkpoint like a CD40 agonist, combining a PDL drug with a CTLA4 drug like Ipi-Nivo, is probably a start, but these studies where we can put a few patients on at a time and really test these hypotheses in real time, and if there's no signal, dropping that arm of the trial would be really beneficial, because then we can quickly test these kind of novel combinations without committing a whole lot of resources and patients to something that's not going to work, and then see what signal and then expand on those groups. And I think there are those types of studies that are ongoing, and I think it's not just sort of chemoimmune therapy, it's chemoimmune therapy radiation, some of these other like stromal modifying agents to try to poke holes in this dense thing that walls off the tumor. I think it's going to be a bit of an all hands on deck approach, and those studies are hard to design because most drug companies are interested in their drug with chemo and seeing if it works or not, and unfortunately those really haven't panned out. What do you think about some of these newer kind of like adoptive cell therapies like CAR T cell therapies? Do you think those have any role in pancreatic cancer or across the GI space?
Yeah, so these cellular therapies have been very exciting particularly in the liquid malignancies, but now starting to creep into solid tumors, including GI cancer. There's been some very early data in pancreatic cancer, but relatively small sample sizes of less than 20 patients or so. So it's really hard to say what's going to turn out there with cellular therapy. I think it's worth further exploration though, because it's been so promising in other disease types. And so I think it'll be important to continue to study that there, maybe in bucket studies where you're combining pancreatic, gastric cancers together to really see if there's a signal there in the cellular therapy space. One thing you mentioned I wanted to go back to is with immune therapy, you raise a very good point that the time to response is much longer with immune therapy. And so in a disease like pancreatic cancer, where the disease moves so quickly, and in general, therapies are not quite effective for us a longer period of time, it's going to be hard for us to really see a substantial benefit, because oftentimes by the time immune therapy has a chance to work, a patient may be already progressing in disease. So it's important to keep that in mind.
Right, and then, then the issue is, should we be studying in earlier stage disease, folks undergoing surgery for pancreatic cancer? We know those patients, even though it's a curative surgery, their odds of cure are still fairly low, relatively speaking, and we give a lot of things like chemotherapy after surgeries like that, but should we be trying other things like immune therapy? I think some groups have tried that. It's hard to do those studies because you need a lot of patients and you have to follow them for long periods of time, and you don't know what you're treating because at that point the patient doesn't have any active cancer. So, that's an issue. And then going back to the kind of CAR T adoptive cell therapies thing, like you said, it seems to work really well in liquid tumors, leukemia, lymphoma. Those have a very reliable target. Those tumor cells all look the same. They're very, what we call homogeneous or clonal. All the, leukemia, lymphoma cells throughout the body have the same surface to them. But, in the solid tumors like we treat, they're much more heterogeneous, and the amount of expression of certain things on the cell surface is so variable that it's hard to get a drug that has a reliable target. And like I like to say, you can have this fancy car, like you can have the Ferrari, but if it has a dumb driver, it's not going to get you where you need to go.
Exactly.
And the targets that so far they've tried in like things like mesothelin or CEA, these things we know that are to some degree expressed on the cell surface of these cancers, they're just not reliable targets. And then you're trying to jazz up the immune system to go after something that one may not be there, or may be expressed on non-tumor cells and cause even more, side effects and things like that. So I think there's unfortunately still a lot of challenges in trying to change or manipulate these really promising, kind of really outside the box treatments in terms of, patients with solid tumors, particularly pancreatic cancer.
Another challenge that patients may face is that you often may have to harvest a tumor or take a sample collection, and there may be a period of time of waiting, generating, engineering T cells, and so that delay, that even if only 3 or 4 weeks, with these fast-moving tumors, could present a problem for patients who are then too ill to receive their therapy.
And that's a big issue with pancreatic cancer across the board. We say tissue is an issue. We're doing more of these liquid biopsies, which is helpful, but not all the tumors seed most of their mutations into the blood. So while we're very excited that now we can just do a blood test instead of having to subject a patient to a biopsy, the biopsy material gives us generally a lot more information. We can do deeper sequencing, derive more information from it, but there's often not that much tissue. For localized pancreatic cancer, unless someone's able to get to a surgery, it's hard to get a big chunk of tissue for analysis. It's only really for patients with advanced disease, and then we can usually do things like liver biopsies. But even then, we're often still pretty limited in terms of how much data we can get out of those specimens. And so that is a big issue, and one that we don't face in sort of the other tumors we're talking about, where there tends to be either patients undergoing more surgeries, we have more access to tumor tissue to do these broader analyses. And that has been, I think, an issue that's definitely hamstrung pancreatic cancer research more than most disease types.
Right. So let's now talk about colorectal cancer, which is, by incidence, the most common cancer that we treat within the GI space. Perhaps let's talk about targeted therapy in colorectal cancer. I'll throw the floor to you to...
Yeah, I mean, it's a cancer type, very common, but again, sort of like pancreatic cancer, historically not a lot of targets. And we do have a greater selection of targeted drugs to use in colorectal cancer. I think the one that's been sort of the newest and exciting is HER2, which, like a lot of the cancers we treat, we borrow our drugs from melanoma skin cancer for various targets, a lot of drugs borrowed from breast cancer world where HER2 very common. We'll talk about with upper GI, I think, in a little bit, but in colorectal, it's pretty rare. I mean, it's only, maybe 5% or so, but more heavily enriched in rectal cancers, and we are seeing more and more young patients, which I'm sure we'll talk more about in a second. But for these folks that have really HER2 positive colorectal cancers, these drugs can work really well. And historically, we've sort of saved this for later lines of therapy, but we might be seeing these drugs being used earlier on, and typically it's combining the breast cancer drugs like trastuzumab with the oral drug lapatinib. There's a lot of excitement about the new breast cancer drug tucatinib, which may be a better version of the pill lapatinib. And then there is this newer drug on the market, which is approved for breast, gastric, and probably soon colorectal, already guideline approved, and that's trastuzumab deruxtecan. And that drug is what we call an antibody drug conjugate, so it's kind of like a smart bomb. So you have the HER2 target on the tumor, and now you have this chemotherapy payload, which is kind of like irinotecan, it's deruxtecan. And that drug can seem to work really well, even for folks where trastuzumab stops working. And it's not without side effects. About 10% of patients get bad lung inflammation, lung fibrosis, and that you need to watch out for that really closely. But that is a new, potential tool in our arsenal. The other things, there's these rare things like we talked about NRG1 fusions in pancreatic cancer. There's NTRK fusions, which are already FDA approved, larotrectinib and entrectinib, which are pills that can target those fusions across lots of different tumor types. Very uncommon, less than 1%, but clearly something we have to look for. But more and more we're knowing that colorectal cancer is, there's about 4% of folks with metastatic disease that are MSI high. Those tumors respond really well to immune therapy. We now think all those patients should be getting pembrolizumab, Keytruda immune therapy up front as opposed to chemotherapy, based on newer data that's come out. And then there's these subsets, if you don't have a RAS mutation, you tend to benefit from drugs like cetuximab and panitumumab. They tend to work for whatever reason in tumors that start from more the left side of the colon, so rectum and near rectum cancers. They don't seem to work as well in tumors that start on the other side of the colon, near the appendix and the small bowel. But these drugs do work, and patients should be getting access to them. So those are the biomarkers we need to pay attention to, I would say, even up front for folks with advanced colorectal cancer. MSI for immune therapy, HER2 for down the road, HER2 targeted therapies, the RAS mutation, so because predicts of lack of benefit of cetuximab and panitumumab. And then the other, newer kid on the block is BRAF. So, that's been a big boon because we have oncorafenib, which is a BRAF drug, with cetuximab, which seems to work really well for folks that have BRAF V600E mutations, again, borrowed from melanoma skin cancer. And that, cocktail seems to work really well in a group that doesn't seem to respond well to chemotherapy. And then sometimes we throw in a third drug, a MEK inhibitor, binimetinib, into that mix, and that seems to maybe increase the tumor shrinkage rate a little bit. But the combo that got approved was the cetuximab with the oncorafenib, which is nice because we can tell patients it is a chemo-free cocktail. It does have side effects, but I have seen it work quite well in some patients. What's been your experience with some of these newer therapies with colorectal cancer?
I think it's just so cool that we have so many different targeted therapies now. Even 5 years ago, we didn't have these options, and it's truly targeted therapy where you can identify, okay, where in the origin in the colon is the cancer? Is it right side? Is it left side? And what are the specific mutations for that patient? And you can really tailor their therapies, so you can choose a patient. You can decide whether or not you want to use a triplet therapy, using 3 different chemotherapy drugs up front, which we are now realizing may be beneficial to hit these tumors hard, higher response rates, and likely longer overall survival. Perhaps combining it with targeted therapies, whether it's a Avastin or EGFR inhibitor. So I think it's been really exciting to see that we have these almost tailored therapies for our patients that we didn't even have a few years ago. I think that in the colorectal space, we're doing really well with first, second line options, but we need to focus in more in third line and beyond to find when these tumors are becoming more resistant, and we've utilized the big guns up front. What do we do now for patients who are still with good performance status, maybe 3-4 years into the disease, but need another option for therapy? I think that'll be a space that's ripe for growth and development of the new drug options.
Yeah, I think in that space it's a little bit wide open. I mean, we have 2 FDA-approved drugs, trifluridine tipiracil and regorafenib, neither of which are really home runs. They're sort of singles. They can keep tumors stable for a period of time. Some folks seem to derive some longer benefit, but that's rarer. We're always trying to make immunotherapy work in this space, but kind of like pancreatic cancer, it's sort of been a colder tumor environment for the most part, with some exceptions. The big exception is the MSI high group. That's only about 4% of advanced colorectal cancer. So, what do we do for the other 96%? So there's been a variety of, trials of combining some sort of targeted therapy with immunotherapy. The one that sort of has made it the furthest is combining regorafenib with a PD-1 drug like nivolumab. That seemed to work really well in some East Asian studies in both gastric cancer and colorectal cancer that normally, you would expect like a 0% tumor shrinkage rate, and now you're seeing tumor shrinkage rates 20-30%. Doesn't seem to have panned out as well in the American experience, especially for folks with liver metastases for reasons we don't fully understand, but maybe those tumors are more resistant to this type of combination. And anecdotally, we see a lot of patients who've had a lot of immunotherapy on various clinical trials, and then they often will come to us and say, like, well, now what? And I have seen those patients actually benefit from things like regorafenib, drugs that target the vascular endothelial growth factor receptor pathway, anti-angiogenic drugs, for whatever reason, there seems to be some sort of magic sauce, some synergy there where combining an anti-VEGF drug with immune therapy seems to work. And the folks who've been on regorafenib for longer than I would have expected are those folks who have heavily pre-treated with immune therapy. So there is clearly some signal there. How we get there and how we manipulate it, I think, is still kind of too soon to really tell. And it's probably in the future not just going to be one immunotherapy drug, it's probably going to be these different combinations of different checkpoints in one. How are you approaching more earlier stage colorectal cancer? Are there any newer technologies there that excite you in sort of how we manage folks who undergo curative surgery for colorectal cancer?
So, I think the debate has always been in terms of adjuvant therapies for stage 2 and stage 3 patients. We're pretty confident. We know that stage 3 patients benefit from chemotherapy. In stage 2 colorectal cancer, it's a little bit more difficult to decide. So certainly the use of some newer technologies is going to be helpful here. Perhaps the use of ctDNA, where we can, via a simple blood draw, determine if perhaps a patient has residual disease, and using that technology to help determine whether or not there's a benefit of giving them chemotherapy. I think this technology is moving very quickly, and we hopefully soon will have an answer to be able to utilize this in general practice. But that's one area of excitement where the goal is to really spare patients who may not benefit from chemotherapy, spare that toxicity from chemotherapy, as well as patients who we think perhaps could benefit from chemotherapy because there's residual disease. Using adjuvant therapy in that space is going to be important. And just a general principle of 3 versus 6 months of chemotherapy. For years we used 6 months of FOLFOX, which we know causes neuropathy and can impact quality of life as patients are done with their therapy. And we now have very strong data that 3 months of therapy is adequate for a select group of patients with limited positive lymph nodes. So that's really an exciting breakthrough in colorectal cancer, being able to really limit the use of chemotherapy for patients with lower risk stage 3 disease.
Yeah, I think ctDNA is very powerful and has a chance to really change how we approach folks with earlier stage colorectal cancer. I think we don't quite know exactly yet what to do with the information. If someone's ctDNA positive, we definitely have the urge to give them more chemotherapy. We think probably the folks who are ctDNA positive post-op, we give them chemo and then they convert to ctDNA negative. Those are probably the folks, the minority of folks we know benefit from chemotherapy. We know we probably overtreat a lot of folks because we can't predict who's going to benefit. Right. So if, for stage 3, we think maybe like 1 in 4 patients benefit from chemotherapy, but we treat all 4 patients the same. Right. So it might help save the 2 patients who would otherwise not benefit from chemotherapy, who might be cured by the time we meet them post-operatively, and it might really help select that patient who might benefit. Right. And then the question is that 1 in 4 who's persistently ctDNA positive, despite all of our best, efforts in giving chemotherapy, what do we do with those patients? Because clearly the chemo didn't accomplish what it was supposed to do. So it'll be very interesting, and I think a lot of clinical trials designed around these patients who we scan them up and down. We can't find any, macroscopic, radiographic scan evidence that they have cancer, but there's this blood test that says there's still some DNA from that tumor lingering somewhere. What do we do? Should we be giving them immune therapy? Should we sequence and find some targeted therapy like BRAF? So hopefully some of these ongoing large trials trying to answer these questions will read out and we'll have a better idea what to do. Right now I like it because we use blood tests like CEA to help monitor patients. Are you going to recur or not? So we do blood work, we do scans, we visit with them. The CEA is not a great test. Right. Some patients' tumors don't even make CEA, but we still check it because if it goes up, that could be bad. I find that that's where the ctDNA is really helpful because now you have a better monitoring test. It's more patient-specific, tumor-specific. So, the ctDNA persistently being negative can show a patient, look, your odds of recurrence have now dropped to close to 0. Previously, we had to wait 5 years to be able to tell a patient that. And no patient wants to go through that scan anxiety every 6 to 12 months and knowing. I think the ctDNA could be an early read into that. The other thing we've been using more is Immunoscore, which is a completely different type of test. It's just based on the tissue, and it's really a better test of how many immune cells are in the tumor. And it turns out the more immune cells, the less likely you are to recur. And I find it particularly useful in stage 2, which is sort of all over the place. Stage 2 cancers you can observe, you can give 1 chemo, you can give 2 chemos, but we're probably over-treating the vast majority of those patients because their risk of recurrence is already so low. And
Right.
I find the immunoscore to be helpful because it can further segregate those folks like a high-risk stage 2 patient. So we think about these various high-risk features when we see them. Yeah, your tumor didn't make it any lymph nodes, but it was microscopically trying to get there, or your tumor opened up and perfed a little bit, and that's a high-risk feature, we should give you some chemo. Now, with the immunoscore, if there's a lot of immune cells there, it sort of points to the fact that those patients probably don't benefit from chemo. So that might be another way to spare more patients from things like chemotherapy.
Right. So let's move into gastroesophageal cancer. One of the recent studies that I'm really excited about was in the locally advanced space, so patients who have resectable GE junction cancer, who are treated a la the cross regimen with chemotherapy, radiation, followed by surgery. Survival with that combination is improved compared to the older, upfront surgery followed by adjuvant therapy. But now there was a recent study that looked at the standard cross regimen plus adjuvant nivolumab, so using immune therapy in this setting with the goal of decreasing risk of recurrence. And we see a positive study where that disease-free survival is essentially doubled, which is awesome. And so I think that's really exciting for patients to be able to, because we've always felt like the cross regimen didn't quite give enough chemotherapy, enough systemic therapy, and now with the ability to give adjuvant nivolumab for a year, patients are fairly easy to come in, receive treatment, minimal side effects. I think that's really exciting for our patients to hopefully improve survival in that space. Right now we know that it improves disease-free survival. So immune therapy, at least in the early setting, has been a huge advance there. Let's move to the metastatic setting or the advanced setting. Some recent exciting data came out at ASCO. You want to touch upon?
Sure, and just jumping back to that for a second. So we always get these consults and questions. Patient got chemo radiation, they went to surgery, and at surgery there's still all this cancer there. It's like, well, should we give more chemo? Should we give more radiation? Well, the chemo radiation didn't really do the trick in the first place, so why should we think more is better in this case? But this is great because it's a different modality. I would think we need a better biomarker. So they use sort of residual tumor around at the time of surgery. We know patients that have a complete response at surgery have a good outcome, and they're probably less likely to benefit. Although you can make the argument that maybe some of those patients do recur, and so maybe circulating tumor DNA or something in that setting might better predict who should get immune therapy, which does have side effects. I mean, it's not nothing, but we've had patients on that study, and we think it definitely does something. In the metastatic space, I think the biggest sea change has been like the Checkmate 649 study, where it looks like adding immune therapy to frontline chemotherapy improves survival, not only for folks that have a high amount of what we call PD-L1 score, some marker that we think predicts who benefits from immune therapy. It really benefited everybody to some degree. And so I think that has really changed the standard that really anybody with a advanced, unsurgically resectable upper GI cancer, whether it's esophageal, gastric, squame, adenocarcinoma, they should all be getting probably some combination of chemotherapy with an immunotherapy drug. Typically in our shop we give things like Folfox because it's we find that the easiest, and then the immunotherapy is typically nivolumab based on this data, and then there's some other data looking at esophageal with pembrolizumab, especially for high tumor mutational burden, the esophageal squamous group. But that has really changed things. I think we're sort of doing a disservice to our patients if we're not giving them immunotherapy up front, partly because, as we've talked about, there's time for that to kick in, right? So you're sort of buying some time with the chemo. You can't maintain that chemo intensity forever, so we like to drop down to some sort of maintenance chemo like oral capecitabine, and it's nice to keep something else on board like a monthly nivolumab, which you can theoretically continue somewhat indefinitely. And if patients are going to benefit, again, it's better to give it to them up front. And anecdotally, I've now done this in several patients, and it seems to work quite well. You don't know how much the chemo is doing versus the immunotherapy. But for instance, I have a patient who's MSI high, who, like in colon cancer, we think benefits really well from, immunotherapy, has not had an easy time with chemotherapy. And I'm like, well, let's just do the immunotherapy. We've already bought what we're going to buy with chemo. Let's ride the immunotherapy wave. So This has been very exciting because all the other cancers we've talked about, colorectal, pancreatic, have really not seen a benefit from this immune therapy wave.
Right.
But upper GI cancers, at least for a good subset of them, definitely does. And then like we talked about with colorectal cancer, HER2 is another space where we're having more drugs that can work in this more targeted way. Are there other drugs that excite you in the upper GI space?
So in terms of what's exciting in the upper GI space, I think the idea of being able to utilize potentially an immune for first-line therapy, to be able to use immune therapy without chemotherapy is exciting. Ipi-Nivo combination, which appears to be better than chemotherapy, is I think really exciting because patients often would ideally like to avoid chemotherapy from in terms of the toxicity. So that's something that I'm really looking forward to see how that pans out. And then some other specific targets, like for example, claudin in upper GI cancer is a potential area that we could see some exciting data in the coming years. In closing, perhaps you could maybe shed one thing you're excited about in GI cancer.
Yeah, I mean, I think we're making progress, albeit in fits and starts. I think we are moving the tide a bit with immune therapy in upper GI cancers. I think we're getting smarter about our genetic sequencing in tumors like pancreatic cancer, colorectal cancer, and finding these sort of novel, potentially druggable targets. There's exciting movement on the KRAS front, which is a gene that's historically never been able to be targeted. Now we're finally cracking that shell. And looking at some of these novel combinations of targeted therapy with immune therapy, I think that's really going to be the wave of the future.
Yeah, one thing I'd like to add in closing is really just the paradigm of how we treat our patients. So for years, we've always typically done surgery first, followed by adjuvant therapy, but now we're moving therapies to the initial setting of systemic therapy first, whether it's chemo or chemoradiation. We've seen success in colorectal cancer. There's ongoing studies in pancreatic cancer. So I'm really excited to see how that pans out to determine if we should be using perioperative therapy or even totally adjuvant therapy for our patients, not only with rectal cancer, but perhaps with pancreatic cancer and some gastric esophageal cancer as well.